Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues, we are in the another episode of the interactive workshops on chronic hepatitis B. In the last episode, we discussed the treatment prior to initiating anti-HBV treatment and the role of the HBE. Today, we will proceed further and see that what is the next step or why we should treat these patients. What's the rationale of treating these patients? And this is to know why to treat patients with hepatitis B. I have said this to you, the national history, we discussed this in the previous episodes, that when a patient presents with acute hepatitis B, the patient either recovers within 6 months or enters the chronic hepatitis B phase, and then it may recover, or even the recovered phase may enter into this phase. The chronic hepatitis B phase, it is characterized by the fluctuating level of immune reactivity. And these are the 4 phases of immune reactivity: the immune tolerant phase, immune reactive phase, immune escape phase, and control phase, and immune escape phase. And as the arrow shows, these are interchangeable. The immune tolerant phase into immune reactive phase, and immune reactive phase into immune tolerant phase, then immune reactive phase into immune control phase, and immune control phase into immune reactive phase, immune control phase into immune escape phase, and immune escape phase into immune control phase, and even this into recovered and then coming back. And these are the typical features of these phases. In the immune tolerant and immune reactive phases, it is HBs antigen positive and the E antigen positive, while in the immune control and immune escape phase, and here the recovered phase, this is the HBs antigen positive and HB antigen negative phases. The viral load is minimal in the immune control phase. The next rise phase is the immune escape phase, then immune reactive phase, and then the immune tolerance phase. And when we see this, the cccDNA, irrespective of the phase, this is present in all 5 phases, and this is very, very important. That cccDNA is present in acute hepatitis B phase, immune tolerant phase, immune reactive phase, immune control phase, immune escape phase, and recovered phase. So I can define the hepatitis B as the hepatitis B disease is an invasion of hepatocytes by cccDNA and then staying there lifelong. So this will be my definition, and this is basic important definition to understand the nature of this disease, because unless you are aware of it and you agree to this, that hepatitis B disease is an invasion of hepatitis B hepatocytes by cccDNA, a lifelong infection. So this is, again, we can redefine that the hepatitis B infection is the cccDNA infection of the hepatocytes, and then this whole infection can be divided into 2 phases: HBs antigen positive phase and HBs antigen negative phase. And of course, we can divide this in acute, chronic, and recovered phase. The HBe antigen positive phases are these 2, infection and hepatitis phase, and HB antigen negative is infection and hepatitis phase in the HBs antigen positive, and in the negative, again, the DNA may be positive in all, the ALT depends upon. This is the, when there is the infection phase, there is no or minimal liver disease damage. The liver disease damage happens in the immune hepatitis phase, that is the immune reactive phase, and immune escape phase. This is the serological pattern. Initially E antigen positive, then E antigen negative. The DNA level initially is high, then goes down, ALT levels depending upon the immune reactive phase and immune escape phase, it can go and up. Similarly, the HBs antigen levels titers, they go down. The HBV related damage, few words about this. We all know from pathology, acute inflammation means inflammation and necrosis, and it is characterized by cleansing phase, that all that inflammatory exudates, they are cleared in acute inflammation. In chronic inflammation, there is inflammation and necrosis plus healing, and it goes a long way, more than 6 months. And this healing is either by the in form of the regeneration of the tissue or fibrosis of the tissue. In hepatitis B, this is the fibrosis of the tissue. So HBV virion does not damage hepatocytes. We all know this. This is the inflammation which is initiated by immunological attack on the hepatocytes which harbor the hepatitis B virion. So the chronic hepatitis B is got regarding the fibrosis. There is initially no fibrosis F1, F2, F3, F4, and when there is F4 fibrosis, the liver starts regenerating nodules, and then this is called cirrhosis. So, and again, if the fibrous deposition process is halted, then the fibrous content will reduce in the passage of time because of the normal cleansing mechanisms. So again, to that, our model of the acute hepatitis B recovered in chronic hepatitis B phase. This is the immune reactive and immune escape phase when the fibrous deposition happens. This is very important. So longer the duration of the immune reactive phase or immune escape phase, there will be higher the risk of liver cirrhosis and HCC because of the greater amount of deposition of the cirrhosis. So remember another point, and when a patient is in immune escape phase, this is a damaged liver because of the initial phase of the immune reactive phase, and that's the reason it should be treated accordingly. This slide tells the reveal long-term follow-up of untreated HBsAg positive individuals in Taiwan, and this is the study which correlates the viral load with the cumulative incidence of HCC and cumulative incidence of cirrhosis at the 13 years follow-ups. When the viral load was less, that is the less than 60 units, and 60 to 200 units, 200 to 2,000 units, 2,000 to 20,000 units, and more than 20,000 units. The risk of HCC was 1.3 when it was less than 60 units. It was 1.4 when it was 60 to 200. And when it was 200 to 2,000, risk was 3.6. And when it was 2,000 to 20,000, risk increased to 12.2. And when it was more than 20,000, the baseline DNA level, the risk was 14.9. Similarly, the risk of cirrhosis, when it was less than 60 units, it was 4.5. When it was 60 to 200, it was 5.9. When it was 200 to 2,000, it was 9.8. When it was 2,000 to 20,000, risk increased to 23.5%. And when it was more than 20,000, risk was 36%. This tells us that higher the higher the rate of baseline HBV DNA, higher is the risk of the cirrhosis as well as the hepatoma. And that's the reason controlling of the proliferation and reducing the viral load is very, very vital in the management of chronic hepatitis B. And this tells us that if a patient presents with the immune reactive phase or immune escape phase, we need to treat these patients. If the patient is in immune reactive phase, we need to treat it and push it into the immune control phase as early as possible to limit the or lessen the damage of the inflammation to the liver because of the inflammation and risk of the deposition of the fibrosis. And when the patient is in immune escape phase, again, to push it that into the immune control phase as early as possible to limit the damage to the patient's liver. So if I conclude, why to treat? Liver damage is the only indication. When there's a liver damage, or liver damage is liver damage is there or going to happen, you start these patients on treatment. So liver damage is caused when immunity attacks on those hepatocytes which harbor cccDNA, where HBV replication happens and virion synthesis is happening. So one indication will be to avoid liver damage. The liver should not get damaged. Second will be if the liver is damaged, so either reverse that damage or halt that damage, no further damage, or slow down the process of damage. Or if you cannot reverse, cannot halt, you should slow down the process of the damage. So these are the two indications why to treat these patients. To avoid liver damage, this is if it is going to happen. It has not happened, but it is going to happen, or to minimize liver damage when if it has already happened. So what are these conditions? In hepatitis, you treat these patients to avoid the liver damage. And when a patient has got fibrosis or cirrhosis, then of course it is already been done and you treat this patient. This is a case of HBe antigen positive hepatitis phase, and this is the HBe antigen negative hepatitis phase. These are the two scenarios, and depending upon the stage of the patients, your aim, your targets, they are changed. So, dear colleagues, I stop here. In the coming video, we shall discuss the treatment of chronic hepatitis B. What are the options, how to go about. I hope you are following me in the understanding the basics of treatment of hepatitis B patients, because when you know the basics, when you know the general principles, you can apply to your patients in whatever phase the patient come to you. So I stop here, and inshallah we shall meet in another video that is on the treatment of hepatitis B, and we shall see what are the components of hepatitis B, what are the options available, and how to go about those. Till then, take care. Khuda Hafiz.